Hello, everybody, and welcome to another episode of the Smart Human Podcast. Today, I have the pleasure of talking with friend and colleague, Dr. Vivian Kominos, who is a nationally recognized clinician and educator in integrative cardiology. Today, we're talking about heart disease in women, cardiac medications, supplements for heart health, lifestyle tips, and so much more. So stay tuned. Hello, everybody, and welcome to another episode of the Smart Human Podcast. Today, I have the pleasure of talking with Dr. Vivian Kominos, my friend and colleague, who is a nationally recognized clinician and educator of integrative cardiology. Yes, she's been practicing cardiology for over 35 years and also integrative medicine for about 15 years. She is clinical assistant professor of medicine at the Andrew Weil Center for Integrative Medicine. She is a founding member of the American Board of Integrative Medicine, where she served as vice chair. Thank you, Vivian, for being here. It is a pleasure to have you here and hit some hard questions, but really, thank you for making the time.
Thank you for having me, Aly. I really appreciate it. It's a pleasure.
So let's just get going. I guess we'll start with, what was the kind of the impetus for you to even explore integrative medicine? What turned you into, what was the spark that got you there?
I think we want to go back to why medicine, because, my son asked me this question a while ago. He said, did medicine choose you or did you choose medicine? And I said, medicine chose me. I had no choice. I was born a doctor, basically. My grandmother, whispered into my ear when I was born, you will be a doctor just like my father. So my great-grandfather on an island in Greece was a physician, the island's physician. Got paid in chickens and eggs or whatever. But I think I was just born a doctor. And when I did my internal medicine residency, my second month, I was in the ICU and CCU. And I just fell in love with cardiology. I didn't know anything about integrative medicine. And for the next 15 years or so, I was diagnosing heart disease, looking at echoes, running into the hospital when people were having heart attacks. And, it was like a blood and guts type of medicine I was practicing. It was very, very, exciting. And I liked it. And after a while, heart disease hit my home. And I thought, oh my God, first of all, I'm a horrible wife, because my husband had heart disease. And I'm a horrible cardiologist because I didn't know how to prevent heart disease. And I knew at that time that I had to learn better how to heal heart disease. So I went to a nutrition conference. This was in Tucson in 2004, a long time ago. I'm aging myself. And I met this guy with this big white beard. I had no idea who he was. And he's the father of integrative medicine, Dr. Andrew Weil. So I spoke to him and I signed up for the fellowship immediately. So between 2005, 2007, I trained. I did the 2-year fellowship like you did in integrative medicine. Didn't really know what I was going to do with it. In fact, I did it really for personal reasons. How can I heal my family and myself after this very traumatic experience of watching as catheters went into my husband's arteries. Here I was on the other side of the operators. I wasn't the operator anymore in the cath lab. I was watching as dye was streaming through my husband's arteries, and it was hanging, one artery was hanging by a thread. So what I started doing, because I was still in my conventional 60 to 80 hour a week cardiology practice, and I started, giving out patients some of the things I learned. And eventually a great job opening came up to start an integrative cardiology program in Manhattan. And the rest is history. Since that time, I've been in practice in integrative cardiology until February of this year when I closed my practice.
Ah, gosh, what an interesting story. And so it kind of hit home because it was personal, and that made it of value to you to really explore. And then did you integrate some of I know that when I was learning and training just like you early on, there was this real kind of worry about how do you put this into my conventional Western training for patients? Did you tiptoe in? How did you kind of start to incorporate the comfort level for that?
Yeah, tiptoe is really a great way of saying it. This was another learning curve. This was like, and maybe you experienced the same thing. I thought I was getting re-educated in medicine. It taught me how to look at studies more critically and how to look at evidence that was real evidence. And, what we learn in medical school within 5-10 years, most of it isn't really applicable anymore. A lot of it isn't applicable. So yes, I tiptoed in it and became more and more comfortable with the more I read, the more I learned. And actually, some of my patients were my best teachers. So, I just kept learning, and I'm still learning. Now I'm working for Andrew Weil Center for Integrative Medicine. Great job, where I'm an educator and a writer, and I mentor young doctors and nurse practitioners and PAs, and I'm constantly learning.
Yeah, no, I think it's wonderful. I sometimes talk about that transition of 2 years of training that we had to go through, and then the board certification is sort of the process of mourning, like sort of the Kubler-Ross, because I was mourning sort of what I believed to be the holy grail of healing or medicine. And I realized that we're missing just an enormous amount of very useful evidence-based tools that could be integrated into what I'd already learned. So there was this sort of battle, and kind of loss and mourning. But it's interesting. I think about a career like yours, and I think to myself, if only we could have some of this information way early in our training. And so let me ask you, over the last, say, 15 years that you've been doing, integrative medicine clinically with, integrative cardiology, I should say. Tell me how you are implementing some of these things that you've learned. I know it's a broad question. Like, let's start with some basics. For instance, what do you tell your patients in regards to, what do I eat, doctor? Like, diet. Where that's a biggie. So tell us a little bit about where that conversation goes.
Sure. Well, it's interesting because and I know that diet is a 4-letter word, right? People diet. I love talking about food and nutrition. Yeah, but poor diet is really the chief cause of disease and death globally. So when you consider, the overabundance we have of nutritionally poor food in the Western Hemisphere, and then the underabundance of nutrients in some of the Eastern and developing countries, nutrition is something that is the number one thing that we should learn as health practitioners. And yet, it's the most undervalued thing in training, right? In fact, there was a study of over 900 cardiologists that were asked, what do you believe about nutrition? And almost everybody said it's a cornerstone of therapy for heart health. And yet, less than 10% believed that they had adequate training and were experts in nutrition. So when it comes to how I deal with my patients, and now I work at a volunteer at a clinic for the uninsured, what I like to do is obtain a food diary, a 3-day food diary, and I sit and talk to them and say, well, what do you think that you're eating that's good? What do you think that you're eating that's bad? It's sort of easy to prescribe a diet and say, you need to eat this, this, and this. But that doesn't motivate people into change what they're eating. So basically what I try to do is increase the amount of vegetables and fruits, decrease the amount of saturated fat, decrease the amount of red meat, decrease processed food, which is dangerous, decrease the amount of salt, especially in the population I'm seeing in the clinic, and decrease sugar and additives and toxins, So what we do is we slowly try to build a Mediterranean type of diet. So eat vegetables, all colors of the rainbow. Make sure that that's one of your major food sources is plants.
Yeah, no, I think it's great. The way you're describing your kind of coaching method is meeting them where they're at, which you have and I have both discovered is that's the way to do it. It's not, like you said, prescribing a diet, see you later. It's more working with what people are already doing and kind of tweaking changes to get them closer to that kind of, anti-inflammatory type Mediterranean diet, which according to studies, right, is probably the most well-studied of diets that, worldwide and epidemiologically that actually has real value in terms of inflammation, has value in terms of cardiac disease risk. Am I right? And even recent studies, believe it or not, that are continuing to support this type of diet.
Yeah, the Mediterranean diet has been the most studied, both in, large cohorts, which means, large studies that follow populations for many years. And it's also had randomized controlled trials that have shown that it decreases cardiovascular disease, coronary heart disease, heart attack, stroke, cardiac death. But on top of that, what's interesting about the Mediterranean diet, and let's just first stop and say it's not a diet per se, but a pattern of eating in the countries that surround the Mediterranean. And that's what's so good about it, because you could take somebody that didn't grow up with a yaya like I did, or, I ate a Greek diet, a Mediterranean diet as I was growing up. I mean, as kids, if we didn't eat the bean soup Friday night, we didn't eat. If we didn't eat the fish soup, we didn't eat. I don't think I tasted a French fry or hot dog until I was in fourth grade. Boy, were they delicious. Wow. So anyway, going back, the interesting thing about the Mediterranean diet, it's associated with better cognitive function. It correlates to lower incidence of cancer, lower incidence of metabolic syndrome or diabetes. So it has all these far-reaching effects besides heart disease, which I really love. But, if we don't want to say there's just one diet, right? There's the DASH diet, dietary approaches to stop hypertension, very similar to the Mediterranean diet, but it added lower fat. Mediterranean diet, by the way, is a high-fat diet. I don't know if people know that.
But it's healthier fats, right? I mean, when we talk about good versus bad fats, would you agree that it's sort of, sticking to the plant-based fats but aren't seed oils? So you're talking, extra virgin olive oil. Even coconut oil has some, controversy, but it has more good than bad, generally speaking, in terms of the... Yeah,
there's some controversy about that, but the main fat in Mediterranean is the olive oil and nuts. There's some nuts and seeds. So... Yeah, I think it's, we demonized fat. I don't demonize saturated fat either, but I think that taking saturated fat and decreasing it has been proven to decrease coronary heart disease and cardiovascular disease events. But saturated fat is a really large, heterogeneous fat, so you can't take all saturated fat and say that it's bad. So saturated fat from animals, long chain, big saturated fat is not good for us. We know that.
And stearic acid and some of these other components of saturated fats may actually be good for us.
They may. And there's some, when you look at olive oil, there's some saturated fat in olive oil. It contains a lot of different fats. So, the fat debate goes on. You do have certain proponents of heart disease reversal that are very low fat. If one of my patients wants to go on a low-fat vegan diet, I work with them. I make sure that they're getting the vitamins and minerals that might be lacking in a vegan diet. But, you may be aware of the Netflix special that came on, You Are What You Eat. That's a study that's very interesting that we could talk about if you want.
Yeah, let's talk about it. Tell us about that.
So it's an interesting study. I I'm sure I read the study, put it in one of my document folders and put it aside, didn't think much of it. And then I saw the Netflix episode. And what the researcher did is he took like 20 or 22 identical twin pairs. And he randomized them to either a vegan diet, which is going to be very low fat, or a healthy omnivore diet, meaning that they'd have, a little bit of red meat, but it would be organic, organic chicken, organic eggs, organic vegetables. And what they found was that after, I guess, 3 months, I don't remember, after a certain level of time, the vegan group had better weight, better cholesterol, better control of insulin and glycemic control, glucose control. So, yes, we have some evidence that vegan diet is good. Not everybody can do a vegan diet. I personally don't. But if my patients want it, I work with them.
Would you say that was, because I actually I didn't read the study and I haven't seen that Netflix episode yet, but I guess the question, or movie, documentary, but was it kind of calling out whether or not Mediterranean, which does incorporate high quality meats and chicken and fish and seafood, really, did it call that out as a comparison, or it was just kind of a finding that they were trying to share with people that vegan diets are just as effective or beneficial, perhaps?
I think they were trying to say that vegan diets are just as beneficial. They didn't use the word Mediterranean. What they used is healthy omnivore. Okay. So, maybe I think it was close to a Mediterranean or typical anti-inflammatory diet that we might like.
And that's typically what you follow in general. Having your background, you're Mediterranean clean. I'm just, sharing certain, it's nice when it gets personal because people like to hear what the people, that they respect in terms of their fields do personally. So what are your thoughts on your own diet and your husband's now, actually?
Yeah. So it's interesting. We did change, he had his heart disease at a time of very high stress in our lives. We had a young child. I was working literally, 24/7 some weeks. And we were just getting takeout and probably having more salt, more sugar, more processed food. And we went back to the way that I grew up, which I sort of abandoned when I went, to college and married and kid and, medical school and training. So, I eat generally, what I normally eat, very boring. Breakfast could be Greek yogurt with nuts and berries and maybe a touch of honey or some gluten-free buckwheat waffles with nuts and then salad. There's a salad at lunch that has everything in it. I love cheese. I'm going to say it. Has saturated fat.
So does Andrew Weil. He says that's his weakness too. Isn't that funny?
Oh, okay. I didn't know that, and I know him. So, but I don't have cow's milk cheese. It doesn't agree with me. Sheep and goat's milk. What's very interesting about like feta cheese is that it's higher in calcium and lower in saturated fat than other cheeses, and it's really flavorful. So you don't need to eat a lot, right? And some of the hard cheeses are very good too. But I always get sheep or goat's milk. And then dinner's going to be, some other protein. It could be tofu, it could be fish, chicken. I might have red meat maybe once or twice a month, only because I don't like red meat. I only like lamb. Yeah. So, I do eat a little bit of lamb here and there. Very rare beef. And that's how we eat, a lot of vegetables.
Yeah. And then life thrown in, which could be the occasional ice cream cone or, but yes, actually having in kind of an 80-20 perspective or maybe 90-10 if you're really good at this, it's work. It is a lot of work. Yeah. So let's circle back now to some of the information on heart disease and kind of where we are as a society. Tell me a little bit about, what's the number one killer as opposed to sort of, there's a difference in when we talk about even cancers. There's the cancers that can actually kill you, and then there's the cancers that you can get, which is the incidence, but doesn't often, isn't the highest in terms of death. So we could say that about even breast cancer, which is very high in society, in our population, in terms of getting the diagnosis, but doesn't, because of all the treatments and therapies that have been developed, isn't one of the highest mortality rates. in terms of being able to, in terms of deaths. So tell us a little bit about heart disease. Where does that stand amongst other illnesses, that kind of plague the human population now?
Yeah, that's a great point and a great question, because not everybody's aware that heart disease is the number one killer, not only in the United States, but globally. And it's the number one killer in men and in women. Very, very important, women. And why is that? Because fewer women now than 10 years ago recognize that heart disease is their major threat, their major health threat. Most will list breast cancer. And even though breast cancer is common, it's also very treatable at this point, thank heavens. But when it comes to heart disease, women don't recognize it. If you don't recognize it, then you may not recognize the symptoms. So yes, that up to almost 50% of our population has some form of cardiovascular disease. Almost 50% have hypertension. And coronary heart disease of the blood vessels of the heart that cause heart attacks or, threaten heart attacks, and can lead to heart failure, rhythm problems, sudden cardiac death. That's the number one cardiovascular disease that can kill you, followed by stroke. So this is, it's very common. And 1 out of 3 people will die from heart disease. And as we're living to be older, and since our risk increases as we get to be older, that's the one thing that might get us. Followed by cancer. A few years ago was COVID. It's interesting. The other interesting thing is that there's a lot of social determinants of health that are going to affect who will get heart disease. So, Black Americans, highest risk for heart disease.
And that has a lot to do with is there a genetic component along with sort of access to certain, to foods or socioeconomic background, education, just a number of things that we could, throw in here. But what are your thoughts? Yeah.
Well, that's really a great question because, race is not a genetic thing, right? It's a social construct. It's not based on genetics. So they did this study where they found that, if you take Black Americans and you remove all the other confounding variables, the lack of access, lack of health insurance, smoking, for instance, there's no difference. So if Black Americans smoke more than white Americans, they'll get heart disease more. So when we remove all those confounding variables, there's no difference. We're all the same underneath the skin color.
Oh, I believe that. It was interesting, though. I remember back when I was doing internal medicine back in training that there were certain blood pressure medicines that actually had more benefit amongst African Americans than Caucasians. Does that still hold true, or is that just because the studies at that time were limited in terms of what much of a breadth of confounders they could control for?
Yeah, that's interesting. There are certain recommendations, which, I can't cite off the top of my head, that work better for Black Americans versus whites. We don't have other information for, let's say, Asian Americans, Hispanic Americans. But yes,
politics, there are Democrat, Republican. We don't have that either.
So I'm not sure. Maybe in a few years we're going to find out. Hey, there really isn't any difference. But there's a difference depending on genetic variants we may have.
Yeah.
So depending on our genes, our personal genes, we might respond better to a calcium channel blocker as opposed to an ACE inhibitor, different classes of
just
blood
like
pressure.
Certain foods will raise certain blood sugars in some people, but not in others. Or like the reason I don't like liver, like my husband likes liver. So we're all very different in terms of, sort of those. But it was interesting when I heard that back in the day, because I thought to myself, how interesting that, even back then, 25, 30 years ago, I remember finding that interesting that certain medications actually have been studied to affect different populations, and that's being harnessed to help them so that there could be better decision making clinically. Tell us a little bit more about things that affect our heart health as a species. Tell us about exercise. Tell us a little bit about how you incorporate that into the conversation of heart health, or sleep, and how sleep manages or helps to, help with heart disease prevention or management.
Yeah, you're bringing up some of the real tenets of integrated medicine, right? The lifestyle, right? So lifestyle, nutrition, stress reduction, sleep, physical activity. I love physical activity. I think that it's a great antidepressant. It's a mood enhancer. We know that it decreases the risk for cardiovascular disease. There was this really interesting study done a while ago, and it was done in Europe. It wouldn't be done in the US. It took 100 men with single vessel coronary artery disease, so that they knew that they had blockage in one of their arteries, and they randomized them to either exercise or an angioplasty and stent where they opened up the blockage. And after a year, what happened is that the people that exercised did better than the ones that had the blockage opened. I mean, it's incredible. Multiple, countless of hundreds of studies, maybe even thousands, have shown that exercise is one of the most beneficial things we can do, probably next to stopping tobacco, smoking. It's probably one of the most protective things we can do for our hearts and our general health, not only physically, but mentally. The nice thing about exercise, when I talk to my patients, is that you just start where you're at, right? Even though the American College of Sports Medicine has guidelines for fitness saying that 150 minutes of moderate to vigorous physical activity, aerobic activity a week is necessary, and working all our major muscle groups twice a week is also necessary. We know from data that you could take people that are very sick or sedentary or have heart disease, and they could just start exercising just 15 minutes a day and decrease their risk for cardiovascular death. It's amazing. I also tell people, if you don't have half an hour a day, like what's, most recommendations are, let's do 30 minutes most days of the week or every day of the week. You could take 5 minutes, a few times a day. It adds up. Even that's effective. Mm-hmm. Exercise, when you combine aerobic activity with muscle, with resistance
weights,
training.
Yeah. Mm-hmm. Yeah.
What it does is it's as effective as all antihypertensive drugs that we use. It decreases cholesterol, right? It decreases blood pressure, decreases heart rate, improves heart rate variability, the actual health of our autonomic nervous system. So it balances the parasympathetic and sympathetic nervous system. It helps cognition. So it's the best drug we can use.
Yeah, and it's anthropologically sound. We have millions of years of understanding human evolution to get us at this point in time, and it's really just it makes sense, right? We're meant to move.
Absolutely.
And so I think that's wonderful. And yeah, I like that your message is you don't have to run a marathon to get the same effect as incorporating small amounts that are aerobic, that challenge you. It's not just like kind of a casual walk all the time, although that is great. You do want to, pick up the heart rate above what your baseline is. You're so that you can, sweat, which is anthropologic, to reduce chemicals and toxins, but also to make muscles stronger. And we know that sarcopenia and loss of muscle as we age is a problem. So yeah, I think for all those reasons. How about sleep? What do you tell your patients about sleep?
Sleep, yes. Yeah. Sleep is something insomnia is something I have personal experience with. Maybe it's all those years of getting woken up in the middle of the night with heart attacks. But, sleep is so important. I think what's happened with our society, because we are, exposed to light at all times, we tend to not slow down when we should. So our circadian rhythm is messed up. We were meant to slow down as it gets dark out. So what I try to tell people is I try to first figure out Are they able to go to sleep easily? That's fine. If they can't go to sleep easily, we look at sleep hygiene. Do they have a TV on? Are they looking at their phone or a computer? So for an hour before you get ready to go to bed, and there should never be a TV in the bedroom or a computer in the bedroom. Yes, you shouldn't work in your bed. It should only be for sleep and sex. That's what I tell people. What we want to do is we want to slow down. Maybe do a little bit of yoga or relaxing stretches for sleep. Meditate, maybe read a book, but try to do things. Do your maybe take a bath. Get into this habit where you almost have a ceremonial entry into your bedroom so that you could go to sleep, and that often helps. A lot of times we wake up in the middle of the night and we start, or I think for people that wake up in the middle of the night. And it gets worse as you get older. It's worse post-menopause. What happens is you start ruminating, you start thinking about things. So I tell people if they're up in the middle of the night and they can't go back to sleep and they're just ruminating, maybe get up, put on a low light, write down what you're thinking, maybe read a book under low light, try to get back to sleep. I found personally that meditation helped me. So I'm a transcendental meditator. And I did that because I started looking at the literature. There was evidence that transcendental meditation decreases risks for cardiovascular disease. I said, really? So I started looking at that. And ever since I started doing that a couple of years ago, my sleep is better. I think even my creativity is better. My cognition is better. So I do try to incorporate mind-body techniques into just overall general health. I always ask my patients, what do you do to reduce stress? Usually what's the answer I get? Nothing. I do nothing. But I think that meditation is a good way. Sleep hygiene is a good way. And then seeing a sleep specialist, because a lot of times people have, sleep disorders, right? They have sleep apnea. Yeah. Very, very important, because sleep apnea leads to cardiovascular disease and obesity and diabetes and metabolic syndrome.
Yeah, and I was going to ask you about that because so many people snore now. Now, whether or not it's a overweight thing where we think the neck is heavy and we think of people who snore as having sort of a weight gain or obese or overweight. And sometimes people lose that snoring problem as they lose weight. But we do know that there's a correlation with hypertension, right? High blood pressure. And what's the mechanism for that, if you could share?
Yeah, absolutely. So, what happens is you set up this milieu of inflammation. When you're not getting enough oxygen, your carbon dioxide level rises, inflammation rises, your sympathetic nervous system fires. People have arrhythmias. They could go into atrial fibrillation. They could go into ventricular fibrillation, ventricular tachycardia, higher risk for heart attacks, hypertension, glucose dysregulation. All these things happen because of the chemical problems that occur when you're not getting enough oxygen, right? Your body sees a threat, doesn't have enough oxygen, it's going to release cortisol, epinephrine, all the catecholamines, those dangerous substances that are going to cause problems, right? So, sleep, it's interesting. I don't know if you've had this experience, but people often push back when I say you need a sleep study. But you also said something very interesting about snoring. A lot of us snore, and yet we don't have sleep apnea. But why are we snoring? I think what's happened is we've become a society of mouth breathers. I think that we've forgotten how to breathe. There's a great book out there by James Nestor called Breath. And it goes through a lot of interesting, I don't remember a lot of it. I skimmed through it, but it goes through a lot of interesting things. Like if you exercise with just breathing through your nose, you exercise better eventually. So it's very interesting. So I think breath work, one of the foundations of meditation is really important. And a lot of times if people just learn how to breathe again, the snoring gets better. When we breathe through our mouths, there's architectural changes that take place in our mouths and our pharynx. So when we breathe normally, our mouths can become bigger.
Yeah, no, there's
really
evidence to show that over decades, that we've sort of evolved into a smaller mouth palate, and our breathing, the actual mechanics and size and dimensions of our mouth and breathing areas, and throat and back of our palate have changed. I mean, similar to the way C-sections have changed some of the pelvic widths. Because we do so many C-sections over decades, right? We're also, it somehow is narrowing the width of the pelvic region to do vaginal births. So it's not so surprising to me that we're changing sort of our breathing habits through our, sort of structural changes. But it also argues that we can work on that too. I mean, it also argues that, as you mentioned, breath work. Some people tape their mouths at night. I'm not sure how good that is, but I know that there are all sorts of ways, mouth guards that kind of move the jaw forward and create a better opening. But sleep evaluations, it's funny. People think sort of the same way, like it's work and you have to go to another doctor who may not give them great information or whatever. But I always ask, do you snore on your back or do you snore on your side? If you can have someone in the room, maybe they're single and I don't know, unless my dog can tell me. But the idea is that there are different questions that tease that information out, and it's not always going to be a CPAP machine as the answer, which is for some people very exciting to hear that. So I think it's survival. Your body wants to survive. It needs oxygen. And everything that responds to, this inflammatory response sort of is as a result of just not getting the body what it needs and requires. So thank you for bringing that out. How do you determine heart disease risk? In other words, say you're doing a lot, you think you're being healthy, you're eating relatively clean, you're exercising. But at what stage do you start to look under the hood and try to figure out whether you have heart disease, especially if you've never been told you have high blood pressure, maybe you have some family risk? How much does that play into the timing of when you start looking under the hood for, diagnostic testing for heart disease?
Yeah, so that's a great question because, over the last few decades, we've had some additional methods to risk stratify people. One of those is calculators. We now have a new calculator. The one we've been using for about a decade is called the pooled risk cohort calculator, where you put in certain data, what's your cholesterol, what's your blood pressure, are you on a statin, do you smoke, are you a man or a woman? And that will calculate your risk, estimated calculated risk over 10 years of having a major cardiovascular event, right? But now there's a new one called PREVENT. And what PREVENT does is it not only looks at these traditional risk factors for heart disease, but it also adds in whether or not you have peripheral artery disease or chronic kidney disease, which is also related. So doctors can use these calculators. And internal medicine, general practitioners, family medicine, these are widely available on a phone or on your laptop so that you can, put in the data and make an educated guess and say to somebody, your risk of dying from a heart attack, stroke, or having an event over the next 10 years is very small. All your numbers look good. Your risk factors are good. But the other thing that I like to do in my practice is obtain certain imaging studies, which are very easy to do. They don't take any time. They're inexpensive. And one is called the Coronary Artery Calcium Score. And I think that it's a great baseline to get once you're in your 40s to 50s to see if there's any calcium in the lining of the blood vessels of the heart in your coronary arteries. It's a CAT scan, so it does involve some radiation exposure. It literally takes 1 minute to do. And no dye is injected. You don't need any preparation. It will tell us if there's calcium. So what does calcium mean? Calcium is actually the healing process that takes place in a plaque, in a blockage in the arteries. And if you have calcium, what does it tell us? It tells us you have some heart disease, you have some blockage. It doesn't tell us how much you have. If you have a calcium score of 0, you have no calcium, regardless of your age. Well, if you're young, the chance that you're going to have calcium, it should be low. But let's say you're in your 50s, 60s, 70s, and you have a calcium score of 0, that's great. That's the best prognostic indicator that you will not have a cardiovascular event. The other thing that I like to do, so that's called a coronary artery calcium score. And there are a lot of places you can go and get this yourself. It should cost about $100. Insurance doesn't cover it. What are the downsides of it? I had a downside. I did it. I had a calcium score of 0, but they saw something in my lungs. It didn't look good. Oh, so now I had to get another CAT scan. And that didn't look good, or they didn't know what it was. Then I had to go for a PET scan. So, the downside is it might come up with incidental findings that don't really mean anything. Obviously, my PET scan was wonderful. This was a scar from pneumonia I got as an intern. And I had to work through that pneumonia. But anyway, so a calcium score, more benefit than risk, right? The other thing I like doing is an ultrasound of the carotid arteries, because you could visualize just using an ultrasound. Yeah. Is there any blockage in the carotid arteries? And if you see any sort of start of atherosclerotic disease here, it tells you that you're at high risk. So these are great screening tools that don't involve any risk other than incidental findings, like I mentioned. And they cost a little bit of money and they take a little bit of time. But I love using those in addition to advanced lipid testing. And we can talk about LDL cholesterol, but I'm going to leave it up to you, Aly.
I want to get into, these are great, topics, because these are real practical. And just a couple points about the CT calcium scan. I call it a CT or calcium score, but CT's calcium scan. Number one, it's very low radiation. I actually looked into this. It's upward, it's like an X-ray of a chest X-ray, which is much lower than a classic CAT scan, which is much longer, much more radiation. So I don't want people to think it's just a snapshot. I look at it like it's a snapshot, takes 2 seconds, boom, it's like an X-ray. So that shouldn't limit people. It is not covered, like you said. Insurance does push back. I've used certain codes that got pushed back. So you do have to weigh that in. And same with ultrasound of the carotids, that actually, unless you code it properly or have a pre-existing issue, it's also, so people have to think about those things. But I use those as wonderful screening tools like you do, even for my rheumatoid patients or people who have cardiovascular risk as a side effect or part of their disease, systemic disease. So very useful. Tell us about that the lipid panel that's a deeper dive than what most doctors order for a cholesterol panel. And please tell us the difference.
Sure. So, classically what we do is we basically check total cholesterol, LDL cholesterol, which is one of the causal risks for atherosclerotic disease, for blockages, and triglycerides and HDL cholesterol. And the thing with LDL cholesterol is, again, it's a heterogeneous type of thing, so that you could have somebody that has an LDL concentration of 100, but a concentration just basically breaks up all the cells and says, how much LDL you have in it. So I could have an LDL of 100, you could have an LDL of 100. If my LDL is in 100 particles, though, they're really small, and the concentration is the same as yours, but your LDL is only in 10 large particles, who's going to have the higher risk? It's the person with the more particles. So what we do in advanced lipid testing is we go beyond LDL concentration and we look at other things. So we look at particle number. Each LDL cholesterol carries a dangerous compound on it called apolipoprotein B, or ApoB. So measuring ApoB is actually more predictive of heart disease risk than measuring LDL cholesterol. LDL is a great screener, but we go beyond that now. So we measure apolipoprotein B. And on top of that, everybody, at least once in their lifetime, should have lipoprotein a measured. This is an LDL-like particle that is genetic, Right now, there are some drugs in trials to see that we could decrease it, but we don't have those yet readily available. So lipoprotein A is another particle that I look at. And beyond that, I look at markers of inflammation, the most common being a high sensitivity C-reactive protein. So when we talk about advanced lipid testing, we talk about going beyond the typical LDL, HDL, total cholesterol. And that might pick out people who have normal LDL cholesterols. My husband had an LDL of 80, less than 100, supposed to be great, while he was having his first stent inserted. Okay, so there were other risks there. So, I usually, obviously as an integrative cardiologist, I add other diagnostic things that may not be done in, a conventional practice. I add them sort of routinely because people are coming to me for additional risk stratification, besides doing the lifestyle, the mind-body, the Eastern medicine, and everything else.
And that distinguishes your kind of practice from a conventional Western practice. But it's interesting because these tests can be ordered by any physician, and also gets covered by insurance. Typically, if they're coded properly. So, really the movement, as, you and I were trained to believe also, is that, we wish integrative medicine would be really all medicine. And it wouldn't have to be quartered out to be, let's do a deeper dive, because there's really no, I would say, obstacles other than the knowledge to do those tests. And some doctors are very flexible and they will do those extra tests, whether they're cardiology or not, internal medicine. But so what about the ApoB and ApoA ratio? I've heard a lot about the ratio. Does that play in role, or even the small dense particles? Is that what you mean by the sort of the fluffy LDL versus sort of the small dense? Can you tell us about that?
So that's interesting, and I'm not sure about the ApoB, ApoA ratio. I think what you're implying is, does HDL protect you? And it doesn't, So, I don't look at ratios. I look at actual numbers of apolipoprotein B. If somebody comes to me and they have dangerous atherogenic particles, they have high LDL or high lipoprotein A or high ApoB particles or high oxidized LDL, and their HDL is high, I tell them the HDL doesn't protect you. In fact, very high HDL is dangerous. So the ratio to me is not as important as actually looking and really figuring out the numbers, right? So, and the other thing that I think that lipidologists have gotten away from is just looking at the fluffy, larger particles versus the small particles. That alone also is not going to protect you, because you could have a lot of particles, and I like looking at particle number, and again at the actual ApoB number, and the lipoprotein A number. One thing I heard from conventional cardiologists who I actually really like is, I don't check lipoprotein A because I can't do anything about it. That's not true. So if somebody has a high lipoprotein A, what do? You decrease every other risk that they have as aggressively as possible, right? Because that's also going to decrease the risk. And we do have drugs that are being studied that hopefully will show us that decreasing lipoprotein little a will decrease cardiovascular events. And that's an important point. When you look at drugs and you say, drugs change a number, that's not enough. Do they also change outcomes? Do they improve outcomes, right? And we know that all these wonderful FDA-approved lipid-lowering drugs that we have now, there's 5. 4 of them not only reduce LDL, but they also reduce the chance for heart attack and stroke, which is great.
Are you talking about statins specifically, or
statins is the first drug that was approved back in late 1980s. Actually, lovastatin, believe it or not, is a natural product. It's found, it's equivalent to red yeast rice, or what's found in small amounts in red yeast rice.
Right.
And then since then, I think there's 7 or 8. I forget. There's a lot of statins. So statins is one drug. But then after that, I guess late 1990s, ezetimibe or Zetia came out, which prevents the absorption of cholesterol from the gut. And this increases the LDL receptors in the liver that get rid of the bad cholesterol. And then we had the PCSK9 inhibitors. So the 2000s, 2010s have been really good in the 2020s because we had PCSK9 inhibitors, which are shots that you get every 2 weeks. We have 2 of them that are FDA approved that also decrease LDL. And interestingly, they also decrease Lp(a), but that's not what they were developed for. Okay. But they are being studied for that. And then we have bempedoic acid, and we have inclisiran. Inclisiran is still new. And the nice thing about that, you get 2 injections initially, and then you get an injection every 6 months. So let's say you have someone that travels and they can't be bothered. Let's say statins don't work. They've had side effects from statins or Zetia, and they don't want to take a shot every 2 weeks. They're traveling. You could do the inclisiran. So we have all these options available to us now that we didn't have even 10 years ago. So, statins, unfortunately, have gotten a bad rap. They're one of the most studied drugs for the longest period of time. Hundreds of thousands of participants. We have genetic studies going back over 50 years on lowering LDL and how that lowers heart disease. And then we have studies, randomized controlled trials that are at least 5 years long that show that LDL works, right, to lower heart disease and stroke with statins. So statins are great. There are people that have side effects. I probably see more of them than the average person or the average cardiologist because they come to me since they can't tolerate the statins and they want alternatives. So we deal with alternatives. And sometimes I'll use other drugs, and sometimes I'll use botanicals or diet, exercise, stress reduction. Even reducing stress reduces cholesterol.
This is great information. And yeah, so many questions keep popping up. I just, I wanted to throw a couple at you. So when it comes to statins, you're right. They've gotten a bad rap. There was kind of a question as to really how they affect metabolism of the cell, whether they lower CoQ10. Do you typically push, if you need in a patient, again, everyone who's listening, it's very personalized, your history, all of this matters into this decision making. But as a sort of a general rule, do you try to use the red yeast rice that are clean versions of statins, or I should say like natural versions, depending on the brand, of course, quality, before they move into pharmaceutical grade? Do you consider the CoQ10 versus ubiquinol addition as sort of like a must-have when you take statins in general to offset muscle-related issues? What are those tricks that you or your preferences when it comes to using the statins in general?
There's several questions there, I think, but anyway. Anyway,
so
I don't use red yeast.
Yeah.
I don't use, if somebody wants to use red yeast rice, I try to convince them to use statins. It's pharmaceutical grade. With red yeast rice products, there's always a chance that you might get, contaminants. And red yeast rice, if they're really just a supplement, they will contain very low amounts of statin. But so I do try to get them to use statins if they're tolerated. If they absolutely refuse and do agree to use red yeast rice, what we do is I treat it just like a drug, and you have to take usually 2 pills twice a day. And some people say, I don't want to take 4 pills a day. Okay, well, what do you... But in any case, you do have to use up to 2,400 milligrams of red yeast rice. And please don't go out there and do this yourself. Right. Because like a statin, you should be followed by with blood tests, because like a statin, they can cause muscle-related symptoms. Right. They can cause some elevation in liver enzymes. So, it should be monitored. The nice thing about red yeast rice is we do have outcomes data on it. It's the only botanical we use for dyslipidemia for high cholesterol that actually shows that it works to decrease cardiovascular events. So that's great with red yeast rice. But there's other botanicals too, like citrus bergamot, and we can get into these. Yeah.
Earl Grey tea. So people that realize, I love it.
I
But
love
that
the Earl Grey
fruit
tea.
called bergamot, which comes from Italy, is one of the rare, I mean, I don't know where else it's grown besides a small town in Italy.
Right.
But
You're
that
right.
flavor of Earl Grey tea that people, is very unique and distinct, that actually helps to lower LDL cholesterol. I don't know if they can decipher small, dense, or fluffy, or what have you, but it tends to lower total LDL. So that's a very good, I guess, recommendation for people who do like tea and are tea drinkers.
Right. And
Or
if you're
supplements,
drinking,
yeah.
Yeah. That's true. Oh, and you asked about CoQ10. Yeah. So if you do red yeast rice, it also decreases CoQ10. So what's interesting about CoQ10, the heart has the highest concentration of CoQ10, right? And as we age or as we get certain chronic diseases, it decreases. I personally do take some CoQ10, but do I know if it's helping or not? I don't know. I'll let you know if I'm 100 years old and still running, right? But I do recommend CoQ10 to people that are on statins or red yeast rice. And the other thing where CoQ10 has evidence is in heart failure. So taking CoQ10 actually decreases hospitalizations for heart failure if your heart muscle is not working well enough to give you the cardiac output that you need. So CoQ10 has it's one of my go-to supplements for some of my patients. But again, please do not take supplements without talking to your doctor.
And would you say ubiquinol, which is the more active form of ubiquinol, of CoQ10, I apologize, would you say that that's a better way to go because some people genetically can't turn an inactive component such as CoQ10 into the more active form where it's more useful?
Yeah, I like ubiquinol, but to be honest, when they did tests, they found out that, some of these, depending on the absorption, depending on microbiome, depending on so many things, not all the forms of ubiquinol would work and some forms of CoQ10 work. I like ubiquinol. I do recommend that one just to give the benefit of the doubt.
Yeah. Okay, great. I mean, this is really great information. And really the reason that this seems to offset some of the muscle aches, which I as a rheumatologist see on, with people on statins, which is, again, not terribly common, but when it happens, it's very irritating, is because the ubiquinol and CoQ10 components are really part of the metabolism through the mitochondria of the cells. Yeah. And so really that's why that got such a bad rap with sort of a mitochondrial poison, so to speak, with statins. And so, basically people who need to be on them should be on them. And I think you and I would both agree as integrative doctors, we also follow guidelines. Right. And, we wouldn't want to just say stop a medicine, especially if you've had a history. This is secondary prevention. If you've had a history of heart attack or stroke personally, I mean, this is when you really want to, take medications very, very seriously, pharmaceutical grade. Yeah.
And for primary prevention, if you're at high risk or very high risk, right?
Yeah, exactly. I just want to make sure people understand integrative medicine is not off the rails, that it's very much guideline driven, evidence-based driven. We work with and our doctors ourselves that are Western trained as well. So, that's kind of the component of integrative cardiology that I think is so interesting from you, is that you have all these added information that you get to share with your doctor in terms of nutrition and diet and sleep and things that really make us a whole person, In terms of, overall training, and I know you've been so actively involved academically with the Andrew Weil Integrative Medicine training and with mentors, what are your thoughts on cardiology training? Do you feel that, wouldn't it be great if we could integrate some of this material into conventional Western, but do you feel like we're making some strides in sort of overall in terms of education of patients through Western and integrative approaches?
Yeah, I think in cardiology, it's being seen. And the reason I say that is because when I open up the Journal of the American College of Cardiology, I might see an article on meditation or an article on acupuncture in the Journal of the American Medical Association for, acupuncture for angina. That's where that great article was published a couple of years ago. So it has seeped into traditional medicine. And the other reason why I think it's changing is because us as medical practitioners ourselves are seeing that we need this. Not only are our patients asking for it,
Right.
but we ourselves need it. We need it for our own self-care, for our own health, and we see that we need to, learn more. We need more nutrition. We're asking for it. So I love the fact that I'm seeing younger people like out of residency applying for the fellowship. It used to be that the fellowship attracted, mid-career, late career doctors, like mid-career, like myself. But now it's attracting, people right out of residency or just finishing up their residency. So I think it's really important. And the other thing that I've seen is that there's integrative medicine curriculum that is being applied to so many medical schools now. So yes, in cardiology, especially because so much of heart disease is preventable. We didn't talk about this initially, but the Nurses' Health Study, when I first read that, which took over 80,000 women and followed them for at least 10, 15 years, maybe even longer now. And what they found was that there was just certain lifestyle, very simple lifestyle things that were associated with an 82% reduced risk of heart disease. And they were basically exercising every day for 30 minutes, eating a lot of plants, fiber, omega-3 fatty acids, not smoking, and having a healthy weight, drinking a little bit of alcohol, although that's debatable now. We know that alcohol is a neurotoxin. And they had a decreased risk for heart disease, a tremendous decreased risk. So yeah, I think cardiology training is changing. Too slow for me, but more of us are going into integrative training at this point.
Yeah, I'm very optimistic. Even more programs are being developed to train doctors. So, it just goes to show you there's a need, there's a want, people are willing to pay for it, even if it's outside of all their years of training and all of their debt from medical school, that people are still interested. So it's kind of interesting. What are the symptoms that maybe a woman who is busy and working and she may have thinks it's indigestion, maybe she thinks she's too young to experience a heart attack. Tell me what you would tell a patient to look for or concern about and to take seriously when it comes to, being, and even young women who I see statistics on, even women going into pregnancy, young women who have higher risks of heart disease even going into a pregnancy, which can be very stressful on the heart.
Yeah, these are all incredible points. And let's just talk about pregnancy for a minute. One of the chief causes of pregnancy complications and, disease or death during pregnancy is cardiovascular disease. Women are becoming pregnant later in life. They have, there's a higher risk of with diabetes, with obesity that we're seeing in pregnant women. So cardiovascular disease, definitely horrible to have during pregnancy. But women, there's this misconception that women don't present with chest pain when they're having a heart attack. But there was a study on that compared women to men presenting with heart attacks, and they were in the younger to middle age group. And 90% of the women that presented, similar to men, were having chest pain or chest pressure or chest discomfort. The problem is they also had several other symptoms, like 3 additional symptoms compared to men. So they might be more fatigued or more short of breath or sweaty or just feel lightheaded or have palpitations. So they might have other, and sometimes when you have a lot of symptoms, then maybe the chest discomfort gets overlooked. But please, if the woman is having any sort of chest discomfort, whether you think it's pressure, tightness, squeezing, anywhere from the diaphragm up, anywhere, pay attention to it. And then if you go to your doctor and your doctor doesn't listen, then go to another doctor. And because what this study showed is that more of these women that were having chest symptoms before their heart attack went to their doctors, and their doctors ignored them compared to men. So, right now there's a big disparity that we're trying to work on to make sure that, number one, women understand the symptoms. There are some symptoms that women may have more frequently than men, such as just fatigue. All of a sudden your exercise tolerance goes down. But remember, it's still chest discomfort, very, very important sign. But
and this
fatigue,
goes for women that are also menstruating. I mean, these are also
Yes.
premenopausal. See, that's another misconception. We all think that, and I say often to patients as well in the past, that estrogen is protective, that estrogen, you won't have as much of a risk of heart attack until after menopause. So in a way, it's downplaying people's, it invalidates people's symptoms, women's symptoms that are premenopausal when they happen, and maybe they think it's a panic attack or it's too much stress and they should go lay down. Am I right? It has nothing really to do with the estrogen capability at that point. It's really, you got to take it seriously.
Right. I mean, yeah, as we go through menopause, our chance for heart attack does increase, right? But, definitely take it seriously. And, the problem is we're still looking at women as just not being at risk for heart disease. And it's not just women themselves. Very few women realize that this is their biggest health threat. It's doctors also. We need to re-educate everybody. I remember I wrote a little thing for Medscape on the Widowmaker. I hate that because what is that telling you? It's telling you the Widowmaker is blockage in the main artery, the left anterior descending artery, one of the big arteries.
Right.
It was nicknamed the Widowmaker in medical school when I was in medical school.
Right.
It's still being used. A friend of mine called me and said, "Oh, they told me I had a Widowmaker." Well, what does that do? It says, oh, first of all, heart disease occurs in men because it causes widows. It creates widows. But the other thing is, hey, guy, you almost died. That's a horrible thing to tell somebody when you have them on the cath lab and you're inserting catheters into the heart. Oh, you have a Widowmaker. That's like, it's like medical hexing. So yeah, I think, for women, please, please, please pay attention. Pay attention to your symptoms and make sure you're heard. One of the main things we do in integrated medicine is we learn to look at the patient as an expert. They're the expert in their health, right?
Yeah, I think it's a great message that we're going to probably close up on. But, the idea of validating your patient, listening to your patient, believing your patients, I think that may have gotten lost in medicine over the last few decades because of the 15-minute intervals. And it's the system. The system is really not set up to have those lengthy conversations where you tease out really important information. So tell me, what's the next phase of your life? You're retiring. You retired, and you're still teaching. So just tell us, what does the next phase look like to you?
Oh wow, what a great way to end this. But I'm still working. I have this great job with the Andrew Weil Center for Integrative Medicine. I guess it's a retirement job, but I've been doing it for the last 15 years or so. So I haven't really retired. I do volunteer at a clinic for the uninsured so I see patients there. I'm on their board of directors. Great clinic here in Red Bank, the Parker Family Health Center. I love it. But I think what changed for me the last couple years that made me realize it was time to give up a medical practice of my own was my granddaughter. I have a 2.5-year-old, gorgeous, beautiful, energetic, wonderful granddaughter, and I want to be with her. I want to just be with her and enjoy her while she still likes me.
So
the next phase of my life, I hope to continue teaching. I hope to, reach out to the community, give back to the community and volunteer and play with my granddaughter.
I think that's a wonderful plan, actually. I really do.
I'm blessed.
Yeah, no, it's a pleasure. It's a pleasure to know you. I think people don't realize you were the reason I got into integrative medicine back in the day because we were on hospital staff together and I had heard you talk about all of this. And I think even Andrew Weil came to speak, which was really an interesting event. So I thank you personally for supporting my entrance into this wonderful, I want to say fraternity, but I'll say sorority, because it is a group of really fine people, and you were really remarkable with all, and also the training that I've received through some of your educational work through Andrew Weil. I mean, you just really have been such an amazing force of cardiology information for this integrative community.
Oh, you're so kind.
So thank you for
Very
that.
Kind.
And I wish you the very, very best. So thank you so much. And I'm going to end on one quick thing. 3 great things people can do right now to protect their heart and to make their heart feel, healthier and reduce disease. Just 3 quick things that you would share.
I would say move more, love more, eat less.
Yeah. Yeah. I think it's a wonderful 3 things. So thank you, Dr. Vivian Kominos. Thank you for sharing your time and your wisdom. And I wish you all the best. And are you going to give fish soup to your granddaughter? Because I know you said that about your yaya.
Oh, she likes fish. Yeah,
there
she
you
likes
go.
fish. I haven't made fish soup in a long time, but she eats beans. She eats everything.
So everything you grew up on, she's getting.
She tried octopus a few days ago. I'm like, I don't eat octopus. But anyway, so she does try everything. She's a great eater. They don't give her kids food. Never had baby food. It's great.
Oh, wonderful.
It's a lot of fun.
Well, enjoy in good health. And thank you again for being here and sharing your,
thank you, Aly.
your wealth of knowledge.
Thank you for the opportunity.
My pleasure.